some of the people in this room have participated in that clinical trial as well. The important thing, the exciting thing, though, is to shift that. We've now seen survival rates really improve in localized pancreas cancer. And we have phenomenal surgeons and phenomenal individuals that can help us with that journey, but the key thing is detection. And what's exciting was, I remember 7 years ago, Dan and I spoke, and he said, early detection is the future. And I said, great, how do we do that? And so no one knew, and kind of knew, but I will have to say that we're very proud the last several years to be participants and involved with a biomarker study. And in the last month, something has changed in a dramatic way. I've had 3 different meetings with various, whether it's industry or cooperative groups, and you're going to start seeing this in the very near future, the actual application utilization of these early detection tests. And this is something that's going to really allow us to take those highly effective combination regimens for advanced stage 4 disease in the earlier stage. So we can catch a cancer earlier and earlier and allow more of those stories that you guys have shared this morning of beating this cancer and looking at the rearview mirror. So I'm excited about that. Again, Roger, I echo Dan's statements. We can't get these things up off the ground without those initial support. The triplet was 10 patients initially, and we saw an 80% response, and it was kept up to 71%. But that led to not only the NCCN guidelines for pancreas cancer, but also for gallbladder and cholangio. So that would have not been done without your support. And the other thing too that it's a privilege to get people together to talk, as Peter and Susan and Doug has mentioned before, us getting together and sharing ideas and sharing strategies, that's the future, and that's how we beat this darn cancer. So just like LSU win the national championship, there's a lot of optimism and hope for pancreas cancer. So thank you.
Glad to show you a softball on LSU. Yeah. You should see his office, especially Mardi Gras time.
That's right.
Well, on deck is research, right? And we're really glad today to have Dr. Haiyang Han, who's going to tell us what he's excited about in ongoing research to try to get the next thing into the clinic, either early or in patients with later disease. Haiyang.
Thanks, Dan. So I'm a PhD scientist, and I study pancreatic cancer in the lab. As Dan said, we do research. We're trying to come up with new therapeutics that can be applied to patients, and also trying to discover new markers that can be used to detect pancreatic cancer early, and also to be used for monitoring disease burden in patients. So we have a few things that we have tested in preclinical models for pancreatic cancer that are promising and ready for clinical trials. One of them is called acoustic cluster therapy, ACT in short. So this is really like a treatment platform, if you like. It's not a therapy by itself. So what it does, it consists of a reagent called sonozoid. So basically it's microbubbles in solution. And the other is the ultrasound. So it combines microbubbles and ultrasound to treat patients. As I said, it's a treatment platform. So what it does is that it improves drug delivery. I'm sure many of you know that the pancreatic cancer is notoriously resistant to treatments, chemotherapy, immunotherapy, all sorts. One of the reasons, or main reasons for this resistance is because pancreatic tumors are very fibrotic, or that the tumors are wrapped in fibers, and so solid, very hard, and so that drugs cannot get in. The reason for that is because there's very few blood vessels in the tumor. If there are blood vessels, they are usually compressed because of the fiber that wrapping up make it very stiff and hard. So this microbubble and ultrasound do is to kind of loosen up the fibrosis. Like Dr. Hussain said that, to modulate the microenvironment. That's exactly what this treatment platform does. So anyhow, when you give the patient the microbubble and then you apply ultrasound and then you apply treatment, chemotherapy, immunotherapy, and what the microbubble does with the ultrasound, it can open up the blood vessels in the tumor so that the drugs can get into the tumor and obviously, deliver to the cancer cells and then kill them. So it's showing very promising activity in preclinical models, as I said, and the next step is for, the physicians to get into the patients. Thank you.
Thank you, Haiyang. We've kind of run out of positions on the diamond, I guess. We were going to have questions, so think of a few questions. But I think you can see that most people are excited by the fact that we have possibly early detection near in hand. If you go to some interns today, they will offer a blood test it's not perfect, right, Christian? And we know that. But we also know that it is now. Many of us dreamed about this, and we don't have to dream much longer. We actually have this. There are certain criteria to have it done. It's not reimbursed yet, but it will be. The Cancer Research UK in the United Kingdom, where it takes about 6 months to get a scan, have red flag people where they get 6 weeks can get a scan, and they're utilizing this blood test. If it's positive, they put them into the higher risk category. Pancreas cancer probably takes anywhere between 19 and 23 years to develop. It's just in the last few years that you start getting the symptoms, right? So there's an opportunity there to do it, and that's what Christian, Dr. Tomasetti is studying, and we hope that the Sina Magowitz Foundation will see that as a next great challenge to identify people earlier and earlier. In breast cancer, as you remember, at least when I started training, breast cancer was a death sentence. Many people realize. They say, in the old days, we'd say, well, we'll take it out, but in 2 years later, the people had passed away. And we learned that the tumor is everywhere in the beginning, and if you apply that therapy that was active in stage 4, that you could make sure you got all the micrometastases, and what happened? Cure. And there's many, many people out here who have marched, and all those dollars that came from marching made a huge difference in breast cancer. We used to cut the children with osteosarcoma's legs off. We realized that the tumor was everywhere. We needed to treat it very early, so even if you get early stage disease, there's less resistant cells. So our immune systems have gotten so tired fighting this, and that's what I'm going to say my last 2 things here. Our immune systems have gotten so tired in fighting this disease that they kind of give up. They got exhaustion. And rather than bother us all the time, it's like a sliver sitting there, our immune systems kind of calm down. So we're looking for ways to excite the immune system again. Peter said, if you have BRCA, then the tumor itself has a lot of mutations, right? And so those mutations are exciting and keep the immune system kind of ready to go. But what happens if our immune system, we don't have BRCA? So what I'm still interested in very much is a study that's being supported by the Sina Magowitz Foundation. It's taken us almost 3 years with the bureaucracies to get this study started. How do we do that? Well, first of all, you have to have a model, right? So this is my AV today. Everybody see the mouse? It's a mouse. Yeah. My rendition of a mouse. Okay? And you see there's a tumor on one side and a tumor on the other side, which would kind of represent people with stage 3 or 4 pancreas cancer or any tumor. So what you can do is you could inject something into one side, but you watch the other side. So if you inject it in one side and the other side goes down or gets smaller, that means that the mouse's immune system has been excited, right? I'm not going to show it on this side. You're all too smart there. So the question is how do we excite the immune system, right? Well, we're kind of at the basics here, but it turns out that you can take a piece of DNA from a bacteria. It's called a CpG island. So you inject it in one side of the mouse, and now you have bacterial DNA in that mouse's tumor. Well, that's okay, but if the tumor's been growing a while, how do you excite the immune system to see it? So at least it says, hey, we're foreign over here. We're definitely foreign, but you know, the T cells that really are the killers, and by the way, those are the people who have long protection from COVID, or the people with T cells are excited. The immunoglobulins are okay, you know, when we inject, but they don't last a long time. But the T cells have a memory. So what can we get the T cells to really get them revved up and get them super T cells? And there's an agent called OX40 that's a stimulant. And it turns out that when you inject both the bacteria in this side and you inject also the OX40, that all of a sudden the T cells, the most important cancer-fighting cells we have, get excited again. They're going to take this out. The good news is, Roger, finally, after waiting like forever, because it had to go through so many different committees, COVID and a lot of other things, this study is now open. And we're hoping that this is open at USC right now. We're trying to get it open here soon, right, Urquhart? And I'll just tell you that the results in the animal models, you can see, this is pretty hard to see, but the red line means that every single mouse survives. And people say, oh, Dan, you know, that's a mouse. But the problem in the mice has not been that's a bad model. We've always said if it shrinks the tumor, that's it. But it turns out if you have mice that survive 45 days with this, any kind of therapy, that's a very good predictor of what will happen in people. And you can see here, this is out to 100 days. You know, that's like a modern miracle in a mouse, right? But that's why we're so anxious and why we're so excited about inciting the immune system to recognize, again, the tumor that's been growing inside of us for so many years. So that's what we're excited about. I'm ready now to thank my panelists here, but also, Roger, I don't know how much time we've got, maybe for questions, but I think it's wide open. We have all the expertise up here on my left and right, and I'm sure they're anxious to and glad to answer any questions. Okay. Questions? We're going to have people take the phone. Okay, question first, then we'll figure out who's going to handle it.
There's a doctor in Miami, just saying. There's a doctor in Miami who is advocating this blood test, and it shows, it says like it's $500, and it shows loads of different cancers. Is that for somebody who has had cancer and is cured, or is that for anybody, or do you think it's good?
Yes, so can you hear me? Yeah. So the test, this one that we have is for all cancers. And we actually are taking down the price to something that today we think it's more like around $100. And it's for all people. The goal is to have the general population go once a year for their regular doctor visit and just take a blood sample and and get the result. And if the result comes positive, it's still not an automatic diagnosis. It's the patient is recommended to get a CT scan to confirm whether the cancer is there or not.
So when you have your, like, I go every 3 months for Everton, so my doctor could add that test?
That's right. The test is becoming commercial, meaning can be sold. And as soon as that is